Welcome to the Hospital Medicine Unplugged podcast. Today we are undertaking a critical deep dive into one of the most time-sensitive neurological emergencies we face, status epilepticus, or SE. Our mission isn't just to review the steps, but to thoroughly unpack the current, protocol-driven, and evidence-based interventions that guide us. That means from emergent therapy right through to the complex arena of super-refractory care for our hospitalized patients. We're synthesizing the latest trial data so you can feel confident in that crucial first 30 minutes.
It's a phenomenal topic because in SE, we are literally racing against the clock, the clock of pharmacoresistance and neuronal injury. Getting the diagnosis and intervention sequence right, well, it's paramount in those initial minutes. To begin, let's make sure we're all operating on the same timeline. The formal definition from the International League Against Epilepsy, the ILAE, it's quite detailed. It states SE is a condition resulting from either the failure of seizure termination mechanisms or the initiation of mechanisms leading to abnormally prolonged seizures.
That sounds great for pathophysiology exams. But when you are actually at the bedside, the operational definition is what really dictates action. For convulsive SE, we're looking at two key clinical scenarios, right? The first one is obvious, a seizure lasting longer than 5 minutes. The second, and maybe a bit more subtle, is that recurrent seizure activity without the patient returning to their full baseline consciousness between episodes. 5 minutes. That is really our starting line for intervention.
Exactly. And that 5-minute mark, that's where the science truly meets the bedside urgency. It's not arbitrary at all. This is the period where that pathophysiological shift begins. It transforms what might have been a self-limiting event into a real medical emergency. See, prolonged unchecked seizure activity induces these detrimental changes in the brain's neurotransmission balance. We start to see a significant persistent increase in excitatory mechanisms, primarily mediated by NMDA receptors. And at the same time, critically, the inhibitory GABA A receptors, they get internalized, pulled into the cell.
So those GABA receptors, the very targets of our first-line benzodiazepines, they're literally pulled off the cell surface.
Precisely. That structural change is what directly leads to pharmacoresistance. The longer the seizure continues past that 5-minute threshold, the fewer GABA receptors are available for our emergent drugs, like lorazepam or midazolam, to act upon. This makes subsequent seizures exponentially harder to control. Delaying therapy means significantly increasing the difficulty of treatment, and more importantly, you're increasing the risk of permanent neuronal injury.
And the risk profile of SE just underscores why we need this rapid response. It's a very common neurological emergency in the U.S., right? The incidence is around 36 per 100,000 person years. The morbidity is substantial, often leading to prolonged ICU stays, persistent neurological deficits, and the mortality risk can be devastating, exceeding 20% when we get into those refractory stages. So the need for a standardized rapid protocol in hospital medicine couldn't be clear.
Absolutely. And the clinical journey, how the patient responds, that really dictates our escalation strategy. We classify SE not just by its clinical presentation, but also by its response, or lack thereof, to our intervention.
Okay, so the first type, convulsive SE, or CSE, that's the textbook presentation we all recognize, persistent, overt motor activity, impaired consciousness. This is what needs that immediate attention, whether it's in the ED or on the medical floor.
Right. But the challenge in the hospital setting, particularly, I'd say, in the ICU, often lies with non-convulsive SE and CSE. This form is subtle, it's insidious. It might just present as unexplained, altered mental status, confusion, maybe even coma, without those classic shaking movements. And because patients are often already intubated or sedated in critical care, NCSE is, frankly, frequently underdiagnosed. This mandates that we maintain a very, very low threshold for initiating early continuous EEG monitoring in any patient with unexplained encephalopathy. If you're wondering, you probably knew that EEG.
And once we start treating, these categories quickly become about treatment failure, don't they? Refractory SE or RSE, that's a major demarcation point. Defined as seizures persisting despite giving adequate, full-loading doses of benzodiazepine and a second-line anti-seizure medication, like levetiracetam or fosphenytoin.
Failure at this stage, usually around the 30-minute mark, that signals the need for continuous anesthetic infusion and mandatory ICU care, no question. And if seizures continue or recur for 24 hours or more after starting that anesthetic therapy, then we cross into the territory of super-refractory SE or SRSE. The resource utilization here is tremendous, and the prognosis gets significantly worse. Mortality rates start creeping towards 25%.
And running parallel to that acute timeline, We absolutely must launch an aggressive search for the underlying cause, right? In the hospital setting, the etiologies are diverse and often, synergistic.
Yes, absolutely. We frequently see structural causes. These can be acute CNS insults, like a massive stroke or an acute intracerebral hemorrhage. Think bleeds, think large infarcts. Or they could be remote insults, like scars from a prior traumatic brain injury or an old stroke. These structural lesions are highly prevalent causes, especially in our older adult population.
Then there are the metabolic disturbances. These are often rapidly correctable if we identify them quickly. You've got to think about electrolyte imbalances, severe hyponatremia, hypocalcemia, or maybe hypoxia from severe lung disease, or even systemic inflammatory processes like sepsis causing acute hepatic or renal failure. We have to check those labs immediately because failure to correct an underlying metabolic issue, it basically guarantees failure of our anti-seizure meds.
hmm And the toxicological spectrum is also vast. Alcohol withdrawal SE is the classic example we all manage frequently. But we also have to consider benzodiazepine withdrawal, which can be just as severe, or intoxication by various neurotoxic agents. We often forget that common hospital medications, things like theophylline, high-dose penicillins, or carbapenems like imipenem, can significantly lower the seizure threshold.
That's a great point. And for patients who come in with a known history of epilepsy, sometimes the simplest cause is the right one: medication issues, non-adherence or maybe subtherapeutic levels of their prescribed anti-seizure medications. That's a leading cause of breakthrough SE. A quick check of the MAR, a call to the family or the outpatient pharmacy that can save a lot of time and diagnostic effort.
Definitely. And finally, we have the idiopathic or cryptogenic cases. These are the ones where a thorough workup reveals no clear structural, metabolic, or toxic cause. These can be particularly concerning because they often signal an underlying, possibly inflammatory process. We're talking about diagnoses like new-onset refractory status epilepticus, NORSE, or febrile infection-related epilepsy syndrome, FIRES.
Can you help us just briefly unpack those acronyms? If a physician hears NORSE or FIRES, what should immediately come to mind?
Okay, so NORSE and FIRES are, frankly, devastating diagnoses. They often fall under this umbrella of acute encephalopathy that includes SC. NORSE is basically S without an identifiable cause after you've done a really comprehensive workup. Everything comes back negative. FIRES is a subcategory typically affecting children and adolescents. It's usually preceded by some kind of non-specific febrile illness a few days or weeks before the refractory seizures kick off. The unifying feature, though, is often an underlying, likely autoimmune or inflammatory process. This requires timely, targeted immunotherapy, not just piling on more standard anticonvulsants. They are sort of the zebra diagnoses that demand immediate specialist consultation, neurology, critical care, maybe immunology.
Excellent clarification. So, having established the severe urgency and the classifications, let's turn to the heart of it, the management protocol. This standardized, stepwise approach is really our best tool for limiting that pharmacoresistance and neuronal injury. We're talking about strict time windows.
Exactly. We break the initial management into 3 critical stages, and the goal is really to control seizures within 30 minutes of onset. That's the target.
Okay, stage 1, initial stabilization from 0 to 5 minutes. The absolute priority is immediate supportive measures, the ABCs. We ensure the airway is patent, administer high-flow oxygen, establish continuous monitoring, cardiac, pulse oximetry, vitals, all standard. And we must put the patient in the lateral decubitus position. It sounds simple, but it's a vital maneuver to mitigate that high risk of pulmonary aspiration during tonic-clonic activity.
And this is also where logistics and parallel diagnostics have to run perfectly, almost simultaneously. The primary intervention is getting IV access. Large bore IVs, preferably 2. But if IV access is delayed, we cannot wait. We must prepare the non-IV routes at the same time. Don't hesitate. And critically, perform that prompt bedside glucose check. Finger stick right away. If hypoglycemia is suspected, or if the patient has any risk factors for Wernicke's encephalopathy, especially a history of chronic alcohol use or poor nutritional status, you must administer thiamine. 100 milligrams the fire. And crucially, before giving 50 milliliters of 50% dextrose the fourth. The order really matters here.
That thiamine before dextrose order, it's something that often gets missed in the heat of the moment. Why is that sequence so vital?
Well, if a patient has severe thiamine deficiency, giving a massive glucose load without replenishing thiamine first can actually precipitate or severely worsen Wernicke's encephalopathy. It works by accelerating glucose metabolism, which burns through the little remaining thiamine cofactor. It's a critical neuroprotection step that literally takes seconds to implement correctly. Give the thiamine first.
Right. And on the logistics side, we need to call for help immediately, rapid response team, maybe ICU consult early, neurology, and meticulously document the seizure onset time and every single intervention. tie in his brain. We also need to anticipate potential respiratory depression because giving those potent first-line agents like benzodiazepines often means we need to be prepared for elective intubation soon after.
Okay, moving rapidly then to stage 2, first-line therapy. This is the 5 to 10-minute window. This is the benzodiazepine cornerstone. The evidence here is just unambiguous. Speed and adequate initial dosing are absolutely paramount. Honestly, the specific benzodiazepine chosen is less important than just getting it in quickly and at the right dose.
For feed agents, lorazepam is often the standard in many hospitals. The dose is beat 1 mg/kg up to a maximum of 4 milligrams per dose, and that can be repeated once if needed. Thiazepam is an alternative at 0.15, 0.2 milligrams, max 10 milligrams, but at shorter half-life. Well, it often makes lorazepam preferable for a more sustained effect, right?
That's generally true, yes. But what if, as often happens in a seizing patient, IV access is just unattainable in that critical 5 to 10-minute window? You're struggling to get a line.
That is where the practical, evidence-based data really shines for us on the ground. We have to stress the non-IV preference when IV access is delayed. Intramuscular, IM midazolam, typically a 10 milligram adult dose, has been shown quite clearly to be non-inferior to IV lorazepam for seizure cessation. This was shown in pre-hospital and ED settings. Its high lipid solubility allows for really rapid absorption and effectiveness. It makes it a highly practical and often faster choice than continuing to struggle for that IV access. Buccal or intranasal routes are also viable alternatives, but IM midazolam is generally considered the gold standard when the vein is elusive.
Good. So if seizures persist beyond that 10-minute mark, despite getting an adequate benzodiazepine dose in, we are now entering stage 3, second-line therapy. This is the urgent control phase, spanning roughly 10 to 30 minutes. This is the time to load a non-benzodiazepine anti-seizure medication.
And this phase represents one of the most significant changes in acute neurology management over the last, say, decade. Primarily due to landmark randomized controlled trials like ESET, the Established Status Epilepticus Treatment Trial, and also Eclipse and Concept. Before these trials, the approach was often very rigid, almost dogmatically favoring fosphenytoin.
Right. The pivotal finding from ESET particularly is the confirmed equivalence of the 3 primary second-line agents, levetiracetam, fosphenytoin, and valproate. ESET demonstrated quite convincingly that all 3 agents, when dosed adequately, achieved seizure cessation and subsequent seizure freedom with comparable efficacy and safety profiles. This is a real game changer because it fundamentally shifts selection away from a rigid hierarchy. Now it's about individualized safety profile-driven choice.
Okay, let's quickly look at those profiles. Levetiracetam or LEV. It's frequently the preferred choice in many acute care settings now. We load it at 60 kilograms up to a maximum dose of 4.5 grams. That's a big dose.
Yeah, it is. LEV's main advantage is its generally favorable side effect profile. Low risk of serious adverse events, minimal drug interactions. That's huge and complex in patients. However, we do have to be mindful of the sheer volume of infusion required sometimes to deliver 4.5 grams, which can take time, and potentially behavioral or psychiatric side effects, although those are less common acutely.
Then there's fosphenytoin.
Yeah.
Historically the mainstay, right? Dosed at 20 milligrams phenytoin equivalents, PE, per kilogram, up to a max of 1.5 grams PE. It's highly effective, no doubt, but it comes with significant logistical caveats.
Precisely. Fosphenytoin requires vigilant monitoring specifically for cardiac effects like arrhythmias and hypotension. It often necessitates central line administration or at least very careful peripheral IV monitoring. And it has a strict administration rate limit. You can't just push 1.5 grams quickly. The rate is constrained, meaning the total infusion time can easily extend towards that 30-minute mark, potentially contributing to delays in getting the drug fully loaded.
And the third option, valproate, or VPA, dosed at 40 milligrams up to a maximum of 3 grams. VPA is a strong alternative, and it can be especially advantageous in patients where maybe cardiac concerns or infusion-related issues with fosphenytoin are prohibitive.
VPA provides excellent seizure control, but you do need to monitor for the acute risk of hyperammonemia, especially with large loading doses, and also dose-related thrombocytopenia. And for female patients, particularly those who are premenopausal, the teratogenic risk remains a major concern. That usually pushes LEV or fosphenytoin to the forefront in that specific population.
Okay, what if those primary agents fail, or maybe they're contraindicated for some reason? Are there alternatives in this stage 3?
Yes, there are. Phenobarbital, while highly effective network meta-analyses suggest very high control rates, it carries significant respiratory depression and sedative risks. especially when layered on top of the benzodiazepines already given. It's often considered more third line now, reserved for when the patient is likely already heading towards intubation anyway. And lacosamide is emerging, dosed IV typically between 200–400 milligrams as a load. Cohort data suggests good efficacy, possibly comparable to the primary three, but we still lack the definitive, large-scale, randomized data like ESET to really support its use as a primary second-line agent. It's often used more as an early adjunctive agent if the first non-benzo fails, or in refractory SE.
So the crucial takeaway from stage 3 seems to be this. Selection must be based on the individual patient, their comorbidities, known drug interactions, potential side effects, and failure of stage 3 seizures persisting beyond that 30-minute mark. That's not just an arbitrary milestone. It signals a fundamental breakdown in GABAergic response, and it mandates immediate escalation to the ICU and starting anesthetic infusions.
That brings us directly, yes, to managing refractory and super refractory status epilepticus. Once we pass that 30-minute mark and enter the 30 to 60-minute window, we are officially dealing with refractory SE or RSE.
And ICU admission is absolutely non-negotiable at this point. Continuous intravenous anesthetic agents are mandatory. Our goal really shifts here, doesn't it? It's about achieving electrographic control, stopping the seizure activity on the EEG as quickly as possible.
Correct. The two agents most commonly used first for continuous infusion are midazolam and propofol. Large international cohort studies, like the Morse code study, indicate these two agents are probably equally effective for seizure control, and they show similar functional outcomes upon discharge, generally speaking.
Let's touch on the dosing strategy, though. We often initiate midazolam infusions after an appropriate bolus, starting the drip around 0.05 2 mg/kg OCH, titrating up. For propofol, infusions typically range from 2 10 mg/kg, again, titrated to effect. But selecting between the two requires some critical care nuance, doesn't it?
It absolutely does. Midazolam's benefit is its familiarity. It's a benzodiazepine, stable hemodynamics generally. But in prolonged infusions, say longer than 48–72 hours, its active metabolite can accumulate. This leads to prolonged sedation and delayed awakening even after you stop the infusion. Tachyphylaxis is also common. Propofol, on the other hand, provides very rapid seizure control and has a fast offset, which makes neurological checks easier. But it carries that serious risk of propofol infusion syndrome, PRIS, especially at high doses or with prolonged duration.
Right, PRIS. Given the systemic complications propofol can cause, severe metabolic acidosis, rhabdomyolysis, acute kidney injury, cardiac failure, we absolutely must monitor closely. That means checking labs like CK, triglycerides, lactate, and watching the EKG, especially when using the high infusion rates often needed to suppress electrographic seizures.
And then there are the barbiturates, like pentobarbital, 0.5 to 5 mg/curie infusion, or thiopental. These are typically reserved for those cases unresponsive to midazolam or propofol. This is mainly due to their dramatically increased risk of severe hypotension and myocardial depression. This just compounds the instability in an already critically ill patient. They often require pressor support.
And absolutely central to managing RSE is continuous EEG monitoring, or CEEG. This is essential, it's not optional.
Definitely not optional. CEEG is required for 3 key reasons. First, to confirm that the seizures have truly stopped, because clinical motor signs might be subtle or completely absent due to the heavy sedation or paralysis. Second, to detect any breakthrough seizures, which are common. And third, maybe most importantly, to accurately titrate the anesthetic infusions. Our therapeutic goal is usually to achieve electrographic seizure suppression. In the most severe cases, we might need to push the infusion until we see a pattern called burst suppression on the EEG. That's periods of flatline electrocerebral inactivity lasting several seconds, interspersed with bursts of EEG activity.
Okay, and if the seizures persist or recur 24 hours or more after starting the anesthetic initiation, then we've tragically crossed into super refractory SE, or SRSE. At this point, as you said, the mortality rate is hovering around 24%, maybe higher. And we are truly dealing with the last resort options.
Yeah, the management becomes truly multidisciplinary here. You need neurology, critical care, pharmacy, sometimes neurosurgery involved. And often we're using therapies with less robust level 1 evidence. Ketamine infusions are increasingly utilized, often starting around 1 mg/kg and titrating up maybe to 5 mg/kg or even higher in some protocols.
Why is ketamine often a favorite escalation drug at this really difficult stage?
Well, it works via a completely different mechanism. It's an NMDA receptor antagonist. Given that the pathophysiology of prolonged SE shifts heavily towards NMDA-mediated excitation, as the GABA receptors fail, hitting that NMDA target directly is rational. And crucially, from a practical standpoint, ketamine often maintains more stable hemodynamics compared to pushing higher doses of potent GABAergic anesthetics like pentobarbital. That's a vital feature in a hypotensive, critically ill patient.
Furthermore, in SRC, especially if that initial workup was negative or unrevealing, we must aggressively pursue and potentially initiate immunotherapy, particularly if an autoimmune or inflammatory etiology like NORSE or fires is suspected.
Yes, delaying immunotherapy in a suspected autoimmune case can be detrimental to the long-term prognosis. We should consider initiating agents like high-dose steroids, IVA, or maybe plasma exchange, even potentially rituximab, even if the definitive antibody results are still pending. That can take weeks. These treatments aren't typically fast-acting for immediate seizure control, but they are critical for modifying the underlying disease process if it's immune-mediated.
And beyond drugs, the treatment landscape includes other adjunctive therapies, though often decided on a case-by-case basis. Things like the specialized ketogenic diet, which can be difficult to implement in the ICU, therapeutic hypothermia, though the data there is quite conflicting for SE, electroconvulsive therapy, ECT, or neuromodulation techniques like vagal nerve stimulation, VNS, and for highly selected focal cases, emergency epilepsy surgery might even be on the table.
So now that we've outlined these time-based protocols, let's just quickly integrate the absolutely crucial component that has to run in parallel through all three stages of treatment, the integrated diagnostic workup. We can't forget the why.
Right. As we established, electroencephalography, the EEG, is arguably the single most important diagnostic tool here. Early EEG is necessary for any patient with unexplained altered consciousness to promptly rule out non-convulsive BSE. Missing NCSE means treatment delays that directly lead to worse outcomes.
And immediate laboratory testing is mandatory, right at the outset. We need glucose, electrolytes, sodium, calcium, magnesium, renal and hepatic function tests, CBC, and toxicology screens immediately. As the hospitalist, you must be actively searching for those correctable metabolic and toxic causes. If we miss severe hyponatremia or acute liver failure, all the loading doses of Keppra or phosphonatoin in the world won't stop the seizures sustainably.
Neuroimaging is also critical, of course. A rapid non-contrast head CT is often necessary right after the patient is stabilized, mainly to look for acute structural catastrophes, hemorrhage, large stroke, mass effect. However, if the patient can be safely transported, an MRI is generally superior, especially for detecting more subtle changes, looking for underlying cortical dysplasia, or evaluating non-acute potential causes of epilepsy.
And if the etiology remains unclear, particularly once you get into the refractory stage, we must be prepared for more advanced etiology-directed studies. CSF analysis via lumbar puncture is necessary if there's any suspicion of CNS infection, meningitis, encephalitis. That's a major differential. And as we discussed, autoimmune and paraneoplastic antibody panels, both serum and CSF, are essential for those new onset refractory cases where you suspect something like NORSE.
Let's just touch on a practical diagnostic concept, especially in that confusing landscape of suspected NCSE, the idea of a diagnostic trial. What does that actually entail clinically?
Yeah, the diagnostic trial is a really pragmatic approach, often used by neurologists. If you strongly suspect NCSE based on clinical picture, and maybe some... Absolutely. Starting with alcohol withdrawal SU. The first-line agents remain benzodiazepines, the V, lorazepam or diazepam are still the go-to, but the nuances are critical. If the patient has known or suspected significant liver disease, lorazepam or oxazepam are generally preferred because they undergo glucuronidation, which is less affected by hepatic dysfunction, and they don't have active metabolites that can accumulate. Avoid diazepam in severe liver disease if possible.
And the single most critical adjunct in alcohol withdrawal is thiamine supplementation. 100 milligram IV, sometimes more. We have to repeat this. It is absolutely essential to prevent Wernicke's encephalopathy. Give it immediately upon obtaining IV access, ideally before or concurrently with any glucose administration. It's also really important for physicians to remember that phenytoin is generally ineffective for pure alcohol withdrawal seizures unless the patient has a separate coexisting underlying epilepsy disorder. Stick with benzos primarily.
Right. Another very sensitive population is the pregnant patient presenting with SE. First-line therapy for acute seizure control remains benzodiazepines. They are category D, but the risk of untreated SE to mother and fetus outweighs the medication risk acutely. However, when we move to the second-line agents, levetiracetam and phosphonatoin are strongly preferred due to their generally better safety profiles in pregnancy compared to valproate.
Conversely, valproate should be actively avoided if at all possible, especially in the first trimester. It carries a significant and well-documented teratogenic risk, particularly for neural tube defects and neurodevelopmental issues. If a patient is already on VPA chronically and presents an SE, the risks and benefits have to be weighed very carefully with OB and neurology input, but it's generally a drug we try to switch away from during pregnancy if feasible.
And we must recognize the specific pathology of eclampsia. If the seizures are clearly eclampsia-related, in the context of hypertension and proteinuria in late pregnancy or postpartum, the treatment paradigm shifts entirely. Magnesium sulfate is the definitive first-line drug for preventing and treating eclampsia-related seizures, not standard anti-seizure medications like benzos or levetiracetam initially. You treat the underlying condition.
Good distinction. Lastly, are elderly patients. This group faces significantly higher morbidity and mortality from SE itself, and also from the treatments. They require extremely close monitoring for drug toxicity, respiratory depression, and especially hypotension, as their physiologic reserves are often lower.
That's right. And while the ESIT trial did include older adults and demonstrated that the main second-line agents, LEV, FOS, VPA, showed comparable efficacy and safety overall in that subgroup, we still must be incredibly diligent in adjusting dosing for their often present renal or hepatic impairment and their multiple comorbidities and polypharmacy. Reduced starting doses, maybe slower infusion rates might be necessary, and the choice must be highly individualized based on safety profile, for instance, avoiding fosphenytoin in a patient with significant underlying heart block or severe cardiac disease.
This has been a really deep and thorough dive into SE management. Thank you. To summarize our key clinical takeaways for everyone listening, the concept of time is the most crucial element. That 5-minute operational definition is the true starting line. Delaying treatment beyond this window quickly and pathologically increases the risk of pharmacoresistance and subsequent treatment failure. Time is brain.
Absolutely. And we must internalize the major clinical finding from ESET and the related trials, the proven equivalence of levetiracetam, fosphenytoin, and valproate for established SE. This evidence really frees us up. We can select the second-line agent based on the patient's individual factors, their comorbidities, potential adverse effects, drug interactions, even hospital logistics, rather than sticking to an outdated, rigid hierarchy.
And finally, the requirement for continuous EEG monitoring in refractory SE is absolutely non-negotiable. It is the only reliable way to know if seizures are truly controlled, to detect subtle breakthroughs, and to effectively titrate potent anesthetic agents, hopefully avoiding unnecessary toxicity while achieving that therapeutic goal of seizure or burst suppression.
Despite the remarkable advances we've made in standardizing the early stage management, that critical 0 to 30-minute window significant evidence gaps still remain for the later stages, for refractory and especially super refractory SE. So if we connect this to the bigger picture, given the really high morbidity and mortality we still see with SRSE, what clinical decision pathways beyond our current standard anesthetics, things like maybe earlier use of ketamine because of its unique NMDA mechanism, or perhaps more timely initiation of broad immunotherapy for suspected autoimmune cases even before confirmation, what holds the most promise for actually improving long-term neurological outcomes in the future? What stands out to you as the next critical area where we desperately need robust randomized evidence to guide us globally?